Hi, I'm Robin from TLC Companions Home Health Care, and I am proud to be part of Radio for a Cure. Health Insurance 101 is so important. This conversation will help people become more healthcare literate. Healthcare literacy is the first step in treatment and recovery. TLC Companions is dedicated to providing quality at-home healthcare to all types of patients, so they can receive treatment and recover at home. We are committed to the fight against breast cancer, and we're committed to making Long Island a better place. Check us out online at tlccompanions.com.
Thank you so much for joining us. Welcome to the New York Cancer and Blood Specialists Radio for a Cure speaker series. This discussion is Health Insurance 101, presented by TLC Companions Home Health Care. TLC Companions Home Health Care is a home health care agency that delivers compassionate care to patients of all types who want or need to be treated at home. So if you happen to be looking to help somebody find quality home care, you could go to tlccompanions.com. We are so happy that they're a partner with us in this Healthcare Insurance 101 discussion. So health insurance, how it works, how to actually maximize and get the most out of your insurance coverage. It's not talked about enough. While prepping for this panel alone, I have learned so much already. I am going along with you. I am just as healthcare illiterate as I think a lot of other people are, hence 101. That's why we're all here. So hopefully you learn a lot, and hopefully this provides a lot of education for breast cancer patients and patients of any and all types. We have to get the conversation started. It's so important because this is one of the most important things really that we have in our lives, and we seem to not really understand how it even works. So joining all of us today are Dawn Savarese, Chief Revenue Officer at New York Cancer and Blood Specialists. I have Dr. Ron Menzin, President of the Nassau County Medical Society and Lead Medical Director for Cigna Healthcare. Finally, we also have Julie Miner, Managing Partner and CEO of J Strategies Incorporated. So we're going to explore together the facts and fiction about healthcare insurance. So I'm going to start with you, Dr. Menzin, going straight to the culprit. Why do you think we react this way? Why do you think I hear Cigna and I get like a shiver up my spine almost? I mean, most people know that they get their health insurance through their employer, but I don't think people understand exactly how it all works. If you could break it down for us, where does the money come from when it comes to putting in a claim and getting it covered?
Well, thank you again for the invitation to join this discussion. I must tell you, not only am I the current president of Nassau County Medical Society and a senior medical director at Cigna, but I also, I'm a patient and I'm a family member of individuals who get healthcare, who have received healthcare. So, and I frequently use that point of view in helping communicate perspectives about the healthcare industry and the resources that are available. So understand that everyone wears many hats in this environment, and we need to appreciate that. Let me start by highlighting something that's fundamental. Healthcare benefits are part of your compensation if you're an employee. Just as you spend your salary wisely, ideally wisely, getting the best value for your salary, I think it's time for everyone to understand that they need to use their healthcare benefits to get the most value out of those awards. And by that, what do I mean by value? I mean getting affordable access to the best possible outcomes. Why do I start with affordability? Because actually that allows for the profitability back to your employer, because these expenses, one way or other, and I'll go into it in a moment, are really translated back to an expense of your employer. For you as an employee, I think it's very important for us to appreciate that if we do this, if we spend our healthcare dollars wisely, we make the employers, the success of the companies we work for, more likely, and financially sound, which keeps us gainfully employed, which is certainly my intention. Let me dive into two aspects. You asked about where does the money come from. So there are basically two in the commercial space, meaning employer benefits. There are two types of funding arrangements. Either one is where an employer sets up, in a sense, an insurance plan. They decide that based on the amount of healthcare dollars that will be spent in a year, they will pay a premium that's likely to be able to cover that amount of healthcare. They are employing one of the typically national, but there are local providers of healthcare, whether it's Cigna, United, Aetna, the Blues, etc. They may set up a plan where there's just as you pay car insurance, you pay a set fee. That's the amount expected for your car insurance each year. And at the end of the year, or wherever the renewal occurs, it's the premiums typically go up, at least through inflation, but maybe also because there were more expenses on healthcare, for example. The alternative, and I'll quickly run through that just to give the alternative, is that employers actually are paying directly for the healthcare services and their dependents of those employees directly through they set up a bank account. It's all the nitty gritty of it is beyond the scope of this call, but they ask companies like Cigna to set up benefit programs and administer those benefits. Why does one company choose that method over another? There are financial implications. There's an ability, and this is what I'll close with, that if an employer is actually helping their employees stay healthy, they should be rewarded for that because they anticipate future year spending will go down for healthcare dollars because they're doing things to help their employees have more affordable, high-quality healthcare. Hope that gives you a general flavor for where the money comes from.
Yeah, I think that was really fascinating to me because I didn't know that your company actually has an account that's covering these costs. So what happens when that account runs out?
Right. Great question. So, first of all, the good bad news is that much of healthcare, there are tremendous workforces, information processes for analyzing what expected healthcare will be. Because of the long nature of it and the actuarial analysis is very deep on these cases. But you are correct. There can be years, especially where there are more catastrophic cases, very, very expensive cases on an individual basis that accrue to a company. If that occurs, they typically have what's called stop loss. It's a form of secondary insurance that covers those rare exceptions when truly astronomical, way above what they expected costs would be incurring for the company. So there's levels of support through what's the secondary market of insurance to cover those situations. If, on the other hand, by the way, those annual expenses were less, those programs often allow for rebates back to or lower costs in the following year on their premiums. So it can go up, it could go down, and that's the beauty of those arrangements. They're called ASO or administrative services only arrangements, by the way.
You had mentioned before how it's beneficial all around for a company to keep their employees healthy because that means they show up for work, right? It's good to have healthy employees. And you were talking about incentives, but you might have mentioned that some incentives are better than others. What incentives that are offered by insurance companies are actually making a difference for somebody or even for the company, and what incentives don't really do so much?
Great question. Fundamentally, though, it starts with during annual enrollment, it's often just click the buttons and move on. And yet, I would ask each employee to pause, do as much homework as you do when you're going online to pick out a new car. See what those benefits and those incentives are for you, because many companies, not all, but many, truly have incentive programs, financial dollars into your health savings account, for example, and I know we can go into that later, but to make a difference. Personally, I am a very big advocate of of incentives that get you to see your primary care doctor. Get a checkup. Make sure that you are as healthy as you believe you are. Have those routine blood work analysis if you're of a certain age, whether it's cancer screenings, PSAs, et cetera, or mammographies, or blood counts and making sure your cholesterol is in line. So I really am in favor of getting connected to your primary care, to a primary care doctor, who you then can use as a resource to navigating the healthcare system.
From an employer perspective, I would also say that employees often don't understand even the plans available to them. And it's really, really important that they speak with their HR department or actually call their insurance company to become educated on that. Their insurance company is actually a phenomenal resource on that. And, as an employer, we actually offer two types of plans. We offer a high deductible plan, which means your monthly payment is less, but your out-of-pocket costs may be slightly more. And that's for people who don't utilize healthcare services as much. We also offer what they traditionally call a Cadillac plan, but really what it is it's a copay plan, where your monthly premium is a little bit more, but your out-of-pocket costs are less. So you may pay $25 when you go to the doctor or $15 for a prescription. And when I speak with my employees, they don't realize the types of incentives they have. So for example, on either of our plans, our insurance offers $600 a year towards health and wellness, which covers physical fitness, gym memberships, things like that. I talk to them about those things. I also say you can call our insurance company and get a printout of what your costs were in a year, your copays, your deductible, your out-of-pocket costs, and then we can actually look at it and see what plan is best for you. Because plans are really tailored to the health needs of patients and individuals. And I think that people don't ask enough questions and realize that both their HR department and also their insurance company are a really good resource to pick what's best for them financially and coverage-wise.
It's all out there. We just have to ask. We really do. We have to ask. We have to do the research, and it's not happening. You have to watch this panel. You have to see what's out there and figure it out, and I don't think enough people do that, which is why we're doing this. And this has been, I don't even know how long this is going to go, because this is great. This is awesome, you guys. Thank you. We could go so much deeper. I do want to talk to Dawn, though. Dawn Severies, the CRO from New York Cancer and Blood Specialists. Would you like to explain what your clinical financial counselors do? Who are they? They are obviously here for a reason, because we are so illiterate when it comes to healthcare that we need counselors to help us. So how are they helping patients figure out their coverage plans and everything?
Yeah, so we do have, I do have a team of the clinic financial counselors. I have them throughout the corporation here. And what they do is they'll meet with new patients coming in and explain their plans. They'll screen them beforehand, get all their benefits, all the information there. And they'll sit with them, they'll go over it with them to make sure that they're aware of the copays, the out-of-pockets, deductibles, and things like that. And that goes across the board for all our entities, because you'll be surprised, but I guess not, of how many people do not know the coverage that they have. They come in, I don't have an out-of-pocket, I don't have a deductible, and and it's $7,800 is your out-of-pocket. So it's very eye-opening. So it's great that we have the staff to do this. So that's what they do. Like I said, we have them across the entity. So it's nice that, that the patients have that one-on-one contact when they come here.
Yeah. I can speak from personal experience. We have a family member going through cancer treatment right now. And the first thing their caretaker said was, Well, we'll just have to sell. We'll sell the house. That's what. But before she even knew what was covered, what wasn't covered, people I think just freak out and automatically think, well, this is it, and we have to pour everything we have into this, and it doesn't have to be that way.
Right.
So it's great that the counselors are there to lay everything out for that.
Well, and she also mentioned something really important, which is your out-of-pocket maximum. Most people have no idea what this is. They're not familiar with it at all. They know what their copays are or their deductible, but they don't know that there's this other thing called their out-of-pocket maximum. And that's where their insurance company actually sets a limit on their out-of-pocket costs in a year. And so you can ask, what is my out-of-pocket maximum? And that actually helps you plan financially for what you may have to cover if you end up in some type of catastrophic health situation.
Yeah, I did not know that was a thing.
Yeah.
Yeah, but the sad part is the patients are not even getting that far when they're choosing the plan. You know, the amount of patients that come in, they're not even aware. You know, there was a time where we saw it with like the Part C plans, but now it's becoming more and more prevalent now that we have the exchange plans and they have the tiered exchange plans. Now we're seeing it more and more where they're just not educated on what they took out, you know, the plan that they took. So it's more widespread.
Could you maybe go into a little bit about what exchange plans and tiered exchange plans are?
So, you know, it's the New York exchange plans. You know, they came out years ago when everybody had to pick an insurance. I guess the Obamacare plans,
right?
That kind of thing. So, you know, when everybody had to take an insurance, you couldn't be uninsured. They came out with all these plans and they were, you know, tiered. So you took a bronze or a silver, and these tiered plans had different deductibles in co-insurances, you know, so some of the deductibles could have been $5,000, $7,000, $10,000. You know, they were not structured accordingly. And patients would just go on and pick a plan and not, you know, see the full picture of the plan. It was just coverage that they had to get. So that's when it really became more widespread, where years and years ago, we only saw it with like a Part C plan, like a, you know, like, not going to call out any names, but, you know, certain plans where, you know, patients who are Medicare eligible took a Medicare Advantage plan and didn't do the research. It was just such a cheaper premium. So they just took that, and then, you know, they're faced with catastrophic illness, and here we are, $7,500 out of pocket. And, oh, I didn't know that, but my premium is $10 a month, you know? So now it's more widespread because we have so many different plans.
Yeah. And we're all making these decisions without being educated on any of it.
Yeah.
And it puts people in a really tough position. Going back to you, John, with your counselors who are guiding people through all of this, how do they help ensure that proper treatment is received regardless of their financial statement? What happens when you just don't have that out of pocket?
So what the counselors do is they'll get grants through foundations. They'll get copay cards. And then if there's nothing available, you know, because grants do close, you know, depending on the disease, then we'll just get manufacturer drugs. So it'll just be free drug. But no, we get grants, we get copay cards. Thankfully, the manufacturers actually have copay cards that cover the duration of the treatment. So, yeah, so we're able to help the patient that way. Yeah.
And Dr. Menzin, you know, I do want to talk about claims and denials. How do you, well, not you personally, how does, you know, Cigna determine what gets approved and what gets denied? How does that process work? Is there a computer system that's inputted? Is it actual human beings that are sitting reviewing every case? How does that happen?
Yes, how does that work?
We all have questions.
All right.
That's my life. How does it work?
Okay. For the next hour, I will be discussing how it works.
We should set up a different call.
So first of all, I want to make an interesting, I was in clinical practice for 13 years. It's a while ago now, but I did not know how the system worked.
Wow.
That was a shame. It's a long time ago. And when I left my clinical practice to become a medical director, I actually gave a grand rounds back at my hospital to explain what we were doing and it was at Cigna at the time. So I want to start with a division. There are benefits that are excluded because they are an excluded benefit. The classic many years ago was orthotics for your foot. You might have foot pain. You needed to go to the doctor to get a specialized orthotic, but a company might have excluded that from a covered benefit. No matter what the medical reasons were, they just said, we're not covering it. Today, more controversial is, say, birth control pills. There could be employers which just say, we're not covering birth control pills. So that's a benefit determination. That has one route of review that's often more electronic, to your point, because it's explicitly stated in the document that covers what is covered and what is not covered. But now to where I think you were really going, which was more about the medical necessity about a coverage situation. So the vast majority of most health plans, most of the activity is just standard medical care. It's not really necessarily reviewed, and it's just standard care. But there are, whether it's high dollar or it's often abused or it's using procedures and or activity, medications, et cetera, which are not only not standard of care, but may not even be yet proven to be effective. They may be proven to be safe, but not yet effective for a condition. Those kinds of situations are reviewed for medical necessity. And they are, although they are often reviewed and may be approved by a nurse, in fact, when they are denied by a medical director, a licensed physician. Different states across the country have different rules about whether that doctor has to be licensed in the state to make that decision, et cetera. Again, beyond the scope of this. But if it's a medical necessity denial, it is first and foremost being authorized, that decision, by a physician, a licensed physician. So I'll pause there and see how you want to go further, if necessary, about that.
Well, I think what a lot of people might be wondering is, how do you get a certain script from a doctor who says, this is my patient, I know my patient, they need this. Why does somebody from a health insurance company come back and say, no, they don't?
So I'll put this is Ron's hat on, because this is, and speak. I want people to be connected to their physicians, but it is fairly well documented in the literature that doctors don't always follow the most current guidelines on occasion. They may be doing things that have ulterior motives for why they are requesting. They may be financial, they may be other about those decisions. At the end of the day, medical reasons need to be submitted when you're asking for exceptions. And those are subject to typically at least one or sometimes two levels of internal review. And the good news for everyone out there is that on medical necessity denials, binding arbitration external reviews are available. So if they think my company or whatever company is doing that review and denies the care, if it's for a medical necessity denial, it is subject to an external review by an independent entity.
So I'd actually like to ask you, Julie, he was talking about how physicians might not maybe submitting for the proper things. Patients typically do have the right to see how and what their physicians are submitting, but people don't necessarily know that. So how would you, explain to somebody that they have rights, what they have rights to, the patient rights to what a physician hands over to an insurance company?
So what I would say to a patient is all of your records and those types of justifications for whatever medication or treatment that they may prescribe to you, you actually have the right to review. You have the right to have access to, and you can actually get that most of the time through your patient portal. But if for some reason it's not on your patient portal, you can call your doctor's office directly and do a medical records request for that. I think it's also really important to advocate for yourself in this situation and know what your rights are. So, for example, as a patient, there are, two ways that I really look at this in New York State, for example. So within Medicaid, if you are a patient on Medicaid in New York State is for the most part contracted with private insurance companies to administer Medicaid plans. So you may be on state Medicaid, but your card says Aetna or Emblem or Cigna or whatever. So with those plans under New York State Medicaid, you actually have something called the prescriber prevails patient protection, which means that for certain medication classes, whatever your doctor thinks is best for you is what will be prescribed. In both Medicaid and private insurance, if you do not have that on whatever medication is being prescribed, there's something called a prior authorization, where your physician can submit a request to your insurer stating the medical reasons why they think you should have that treatment or that medication. If you're still denied, as the doctor said, there's actually an appeals process that you have a legal right to do to appeal that. And the biggest thing is that when physicians and providers make those decisions and are willing to fight for them, it is usually because there is another factor where they think that the patient should have this certain medication or treatment. And it can be a lot of things. It can be a comorbidity. They have other health conditions that influence the type of treatment they need. It can be a social factor, right? The doctor knows this patient and a lot about their lifestyle, and they know that they are going to be more compliant with this type of treatment versus another. But patients should know that if they, show up at their pharmacy and their pharmacist says, sorry, your insurance isn't covering it, that's not the end, right? You have to advocate for yourself. You have to call your physician. And if your physician isn't ready to do a prior auth for you, you actually can call your insurer and sometimes do that process yourself. Again, that's a lot harder. You're going to want to work with your healthcare provider on that, but know that that's not the end all and be all when you receive your first denial.
I would want you sitting next to me. If I ever have to go through that process.
Thank you.
Yeah,
I've actually, I've dealt with it with patients. I've actually dealt with it with myself as well. And so I have personal experience with it and I understand how it works, but most people just aren't even aware that this exists.
Why do you think that is? Of course, it's our medical history. Why don't you think more people know that we don't have rights to that?
I think that the way that medical information is communicated is often something that makes sense to the people in the industry, right? It makes sense to all of us who are specialists in this, but it doesn't make sense to the average person. I was listening to a podcast the other day and somebody said, we're better communicating things on politics in the language of regular Bostonians versus professors at Harvard. Right? It's kind of the same thing. It's communicated in language that often it doesn't make sense to the average person because that's not their specialty. That's not what they go to work and do every day. And so also patient advocacy organizations, your physician, those folks help translate that for people. But the biggest thing is ask what your rights are. If you're not asking, you'll never know.
Dr. Menzen, you look like you're...
Julie is spot on about the process. It's intriguing to me because the fact is that when a denial is issued, I have seen them for myself, and it's written in that document, but it's on page 7 or 8. And after the first page that you said it was denied, people just go throw it up in the air. In fact, the rights about appeal, the rights about timely appeal, if it's something urgent, is also always allowed. But I grant you that it's typically, I could look up the page of one I received years ago that I was going to talk a little bit about. It's on the way buried in the 7th or 8th page. By the way, it's 7 or 8 pages because there's legal requirements that put in a lot of information into those documents. So I don't have a good answer, but it is in there.
I want to get you a little sign. I just saw you dancing. Thank you very much. Thank you. So there's a whole other issue that I wanted to address with you about the process of calling a doctor for the first time. And it goes for any type of treatment, but a lot of people tend to call a doctor's office for the first time and say, do you accept my insurance? And more often than not, an office will say, yeah, of course we do. And then you're surprised with this huge bill. So there is a difference between a physician that accepts insurance and a physician that is in your network or out of your network. So what's the right question to be asking in this situation to make sure we're getting the right information for ourselves?
You've actually, within your question, given the correct answer. Are you in network?
Yeah.
Alternatively, you could say, are you a contracted provider? If you want to speak legalese.
And what is the difference between someone being in your network as opposed to somebody being covered by your insurance?
Again, you now use the word cover, so we're always going to be very legalistically clear about the wording. If someone accepts your insurance, that means they're going to take the payments that came from that insurance company, but they're not guaranteeing you that you will not be balance billed for their total bill that they may want to get paid for. So that's the issue. And that's why that's why when you call, as a matter of fact, I was going to ask you guys, when you call an office, the first thing they ask you is, what is your insurance? I've been doing this for years as a patient. Hello, it's Ron. And they say, what's your insurance? Then you come back and say, are you in network with that insurance? Mm-hmm. That's the way to be very clear about this. Or if you choose to use your out-of-network benefits, if you have it, again, you should be asking, so how much is the gallbladder surgery that you're going to do for me actually going to cost me? What are your charges? Just like you do when you're at a restaurant and you ask, they tell you about special meals.
I just talked about that on my show the other day. Go on.
I did it the other night. I was, very nice restaurant. I asked, how much is that linguine with clam sauce?
Right? It's okay to ask, right? That was the question of the show. But anyway.
I did. They still served it, and I decided it was a good value, and I got it. But I decided it was a good value.
You can also call your insurer or look on their website to figure out who are your in-network providers. Yes. It's really extensive. You can search by specialty, distance from your house. Actually, with our insurance, you can even say, I want a female provider, a male provider, someone who specializes in LGBTQ plus issues. You really actually can narrow down what providers are in network. And that's the biggest, just like the doctor said, in network, that is your keyword.
In network. And Julie, do you have experience with clients and patients who have kind of fallen into that, yes, we accept your insurance trap, as opposed to in network? What would you advise somebody to do if they get caught in this position?
Most of the time they get caught in this position because they've been referred by one of their physicians to another specialist. Or they just, Google, who's the best OBGYN near me, and they're not aware. I would actually say, if you're referred to anyone or if you're considering, check that doctor's name with your insurance company to see if they're in network. Also, a lot of people don't know what their out-of-network benefits are. They don't know that there's actually two different systems here, right? In network is all the coverage you think about automatically with your insurance. Oh yeah, this is covered, that's covered, whatever. But out of network is a completely different ballgame in terms of what is covered and what's not. And it's really important for people to understand their out of network coverage. The other thing that they can do is If, for example, this is a specialty physician that they need to go to for the type of issue that they're having, they can work with that office to see what other types of financial assistance are available in order for them to stay with that provider and it to be affordable for them.
Dawn, I'd like your thoughts on that as well. You know, how do you help a patient pay for or get treatment if they really want to stay with an out-of-network physician?
So it's interesting because a physician within the corporate, within the practice, or if they're going out, because it's
Yeah,
kind of,
if they want to really stick with somebody who's out of network for them.
so luckily we have a pretty robust insurance roster, basically. And we are multi-specialty. So we have, we have a New York Health side where we have PCPs, we have urology, we have breast surgery, we have general surgery, we have imaging, and we take basically every insurance. We make sure that we get credentialed in every available insurance because we are in the boroughs as well. So everything that is out there, we make sure that we are covered. If there comes a time where, if there comes somebody that we have, the one-offs where we're not in that plan, but the patient has to be treated, then we will get the drug however we have to. If we have to go through manufacturer to get the drug, we will obtain the drug that way. We don't send the patients out because, if we're not in the plan for some reason, we won't send them out. We will get the drug. We will, get a special out-of-network authorization, case rate if we have to. So, there's ways around it to avoid, out-of-pockets for them, for sure.
And how do you help the patients if it comes out to they have to get, actually go to a hospital for a procedure or a surgery? Do you have any advice on how the insurance company works with the hospital? Like, or do you have to stand out of that, or do you help them sort of along that process?
No, so because because we're the ordering providers, we have to obtain the authorizations for it. So if it comes back to us that the hospital is out of network, then we'll work with the hospital directly for them to set up a case rate and to make sure that the patient is responsible for anything, that it gets worked out beforehand. Because if the patient then can't afford it, then we'll have to make some adjustments, because we don't want to send the patient anywhere where they're going to get stuck with something that they can't afford right off the bat,
Mm-hmm.
So we have a lot of transparency into that, especially if we are the surgeons that are performing the surgery. But, we're pretty fortunate. We're surrounded by, a lot of area hospitals that are in network. But again, if we have to, work with the doctors and the hospitals to do special case rates and whatnot, we've done that before.
Dr. Menzen, can you talk a little bit about what happens when somebody does wind up in a situation, maybe they're put into an ambulance and they don't, have the ability to choose who's going to take care of them when they're trying to do an emergency procedure on them?
I'll answer that, but I just want to add to that Dawn used a great word, transparency. And I am a major advocate in part of what I'm doing in my work is to make sure that medical care costs are transparent to everyone, both the in-network cost and out-of-network cost.
Yeah.
And it's only fair and appropriate that word becomes part of our lingo for understanding these situations.
Right.
I think, and again, now this is more Ron, and Ron is a medical society president speaking. I think that hospitals that employ physicians and are in network for a plan, but allow certain groups to be out of network that the patients have no control over, I have an issue of transparency about that. The good news is that I believe we're going to get to what's going to be the new out-of-network rules of engagement that are starting in January that will help deal with those situations. But in general, to come back to the response, if it's emergent care and you don't have control over the hospital, you're having a heart attack, and for some reason that hospital is out of network right where the closest hospital, that's where they're taking you, that should be covered by your health plan as an in-network level of benefit. When it's not, you have you have the ability to appeal and review that. And obviously there are even other additional layers that sometimes have to get played out about those costs. But I know that we authorize under those circumstances that care, you had no choice, it gets authorized. The gray area is where you're stable and you're now ready to be discharged or need additional services, and you're in and out of network, if you're in and out of network hospital, etc. But that's a rare situation. And I do believe at the end of the day, the new, I'll get you the exact phrase because I want to make sure I have the new law that's the out of network. Oh, I apologize.
It's referred to usually as the surprise billing.
Right, the Surprise Billing Act. That will go in place at the beginning of 2022, and it doubles down on what's already, for example, in New York State, there's a surprise billing rules, but that only covers a very narrow group of health plans that are fully insured and sitused locally to New York State. In other words, the rules are for New York State, but that'll
this is going to be federal legislation.
It is federal legislation. And as a matter of fact, so timely to this call, yesterday, the federal government just issued additional guidelines on how it will be implemented comes January 1.
Do you want to go into a little detail about that? Did you? I mean, while we're here, you know.
I'll give you my take on it. Oh, actually, I'll read. I just literally from what's called AHIP, which is the American Health Plan Association trade organization. The president of that organization, Matt Iles, just came out with a statement praising the rule, saying it signals a strong commitment to consumer affordability and lower healthcare spending through an independent dispute resolution process that should encourage more providers to join health plans. In essence, if there's a surprise bill, the plan and the provider, whether it's a hospital, whether it's a clinician, has up to 30 days or so to work out an agreement about what they will pay, and if it's successful. If it's not, a baseball arbitration process will go into effect. And if those know baseball arbitration, what that means is two sides make an offer. The arbitrator can't split the difference. He has to pick the high number or the low number. And we'll see how that plays out. But Julie and Dawn, I'd love your take on additional information and perspective about that new law.
Definitely. Dawn, Julie?
Yeah, I mean, I think it's really focused on ambulatory kind of care, like emergency care, hospitalization, that type of thing. But I think it's also focused because in certain states you have this, in New York you have it less, but sometimes you actually have a practice where most of the physicians are covered, but then you have a new physician in or a nurse practitioner, and patients don't know. And there's a real push for transparency. And when you do this, actually, what normally happens, I know some folks who have done it in New York, that then their bill actually gets covered. It takes a little while, but if they get a surprise bill, instead of hunkering down and saying, oh, I have to pay this, it's another situation where it's like, know your rights, Google it, because you do have an ability to basically appeal and say, no, I'm not going to pay this because this wasn't transparent and I didn't get to choose this in the moment.
Wow. Anything you wanted to add?
Well, no, I agree. I mean,
yeah.
Patients call all the time with this, and it's hard because we have so many physicians that round in the hospitals. And, that's, and when the insurances are, we bill it out so fast, and the insurances are, they deny it. Some of them deny immediately. Oh, it needs authorization when it doesn't need auth, or it's patient responsibility, and then it comes back, no, it's not. And the patients just immediately call, they immediately throw that out there. So, it is a little bit difficult. So it's going to be interesting to see how it kind of works out.
Yeah, definitely. And people will have to know about it as well. We'll have to know come January that this is a thing, So I really appreciate you guys joining us today. I'd like to get maybe just some final thoughts from each of you on everything that we talked about today. I guess we could start with Dawn. What would you urge all patients to do to increase healthcare literacy? If there was one thing that everybody has to pay attention to.
I think just be proactive. Just be more proactive, just research more. We don't see that enough, we just don't. It's just, you have to be your own advocate, I think that's just what it is, really.
Dr. Menzin, what can people do to be smarter to maximize their coverage?
I'll double down on the concept of you must be your own advocate. My role is as a medical director is to help employers understand how they are spending their money on healthcare dollars and what they're getting for it. I ask them to be advocates for better healthcare, but individuals, as you yourselves go out and get the care you receiving, understand it, ask questions, don't be intimidated. It's your body, it's your life, and if you are a good advocate for things, you'll get the best outcomes.
I'm noticing a trend here, Julie. What would you say to urge people to get the most out of their health insurance company?
I would say be tenacious. Don't accept no for an answer. I think that one of the hardest things for patients is kind of being confrontational and resilient all at the same time. There are people within the healthcare system that are incredibly committed, incredibly passionate, and will go above and beyond for you. And there are also people in the healthcare system, just like any other facet of life, where this is just a job. They don't care as much, right? And they'll tell you whatever's on their paper or in their computer notes, and you have to say, no, that doesn't make sense. That doesn't seem fair. What are my other options? As a patient, you have to be incredibly tenacious in advocating for yourself and not accept no when it just seems like it's not right.
It's hard to do for some people.
Mm-hmm.
It's really hard to do. Like I said, I want you next to me when I have to.
Hey, I'm telling you, if you have a pushy friend or family member, you bring them with you. They will be the best.
It's true.
Thank you. Thank you all so much. Dr. Menzin, Dawn Savarese, Julie Miner. I hope more people know that their insurance company, they will be an advocate for you. Ask the right questions, but your biggest advocate for yourself is going to be you. That is definitely the big takeaway here. Ask all of the questions, do your own research, and thank you so much. It's so important that we keep talking about this. The healthcare systems keep changing. There's always going to be more questions. There's always going to be new legislation. So it's important that we stay on top of everything. So thank all three of you so much for today. Thank you to TLC Companions Home Healthcare for being a sincere and reliable patient care organization, always advocating for dignity in treatment. And this has been Healthcare Insurance 101. I'm Jamie Morris, and thank you so much for watching.
Thank you for watching the New York Cancer and Blood Specialists Radio for a Cure Speaker Series, Health Insurance 101, presented by TLC Companions Home Healthcare. For more episodes in this series, visit radioforacure.com.